This is another case. He's 75-year-old diabetic, was referred by endocrinology department with resting pain, and there was some ulcer as well. She was known chronic coronary disease patient as well, had PCI done 7 years back. ECG showed normal sinus rhythm, echo, preserved EF, RFTs were normal, CTA left SFA total occlusion.
What was the diabetic control like, Jabbar?
It was not controlled because she was already admitted in, I don't remember exactly, in our endocrinology unit. So we advanced the NSAID sheets, telescoping were the right diagnostic catheters. We initially tried to do true intraluminal wiring, but we failed. We have to advance the diagnostic support catheters to have some support. Again, it failed. So we switched the procedures to 0.35 inch guide wire to have a knuckle. But we ended in this dissection, but the flow was there. We called our vascular surgeon. He said keep her for 48 hours. If there is no acute limb ischemia symptoms, we don't need to intervene for time being. We called the patient after 3 weeks. This was her angiogram. So this time our wire passed easily without any problem. After multiple inflation, balloon long inflation, we achieved this flow. So SFA and popliteal ideal, what should be the ideal strategy? More elaboration on balloon angioplasty with adequate size, at least 2 to 3 minutes, mostly finalized with DCB, but in Pakistan it is hardly available and it's very expensive. If the lesion is calcified, hard ISR lesion, plaque modification with debulking, scoring balloon, peripheral IVL or NC ballooning should be done. If the stent is CTO, then jet stream, NC or DCB, no stent zone, then we need DART, heavily calcified in mid to distal SFA, we need self-expandable stents. Poor balloon response, primary DES. So how we do it in our setup, because we know we are resource limited, for short lesion, Wilny PT and balloon angioplasty is enough. DCB leaving nothing behind. Every effort should be made to avoid stenting, because we usually these patients need future intervention to avoid the chance of stent fracture and ISR burden. With broad anatomical applicability, we should try to leave nothing behind. But DS, because leaving writing behind for poor response to plain balloon angioplasty. In these cases, we need drug-eluting stents or bare metal stents. So where there is a will, there is a way. Thank you very much.
Great. Dr. Jabbar, I have a question. Which stent you are using for the SFA intervention? You are using Supera by Abbott?
No.
Which nitinol stent?
We have actually Apex from the Boston. We don't have Supera in Pakistan available. It is not an stent, and it's quite flexible. It is not as flexible as Supera, but it is acceptable.
Jabbar, what happened to the foot that you have shown? That
yes.
Ischemic gangrene after restoration of the blood supply.
Ali Raza is saying
not the other one, but the
yes. The wound is healed. I don't have these pictures, but usually these patients are taken care by the endocrinology and a surgical team, and usually these once the flow is restored, they healed in 3 to 6 months.
Dr. Jabbar, very nice cases you have shown us. Usually this peripheral arterial disease presents with diffuse atherosclerotic process. You are using long balloons. What do you use?
Yes.
Like you showed. And you also showed that you used Pilot 200 in one case. What was the reason? Was it total occlusion? Or what was it?
The 3 cases I shown, they were CTOs, and dedicated peripheral wires. You know, it is not available in Pakistan. There is only one that we have it. This is Victory 14, and it's Pilot 200, Hornet, these coronary wires, we use it, and it comes in 300 centimeter as well.
Sorry, you are also doing coronaries.
Yes.
What is the behavior? I just want to ask, see, how do these peripheral arteries behave with the same wire which you are using, like these wires for CTOs, as compared to the coronaries? What is the risk and how does it?
In peripheral, the risk is low, but you know, these are hard to penetrate. Usually, these are very calcified and very hard to penetrate with these corneas wire. Dedicated like a stat to 20, 40. I do have some for some cases which I can't do with these corneas wires, but usually these are you know, very tough. While in corneas, they're not as tough except some cases.
Obviously, these patients refer to you from diabetic clinic or diabetic department or whatever. Do you also do the coronary angiograms before embarking on peripheral?
Yes, this is a very good question. Usually these patients are referred by our endocrinology unit from our own hospital or from Hyderabad Medical Complex or somewhere else. So each patient, even if their sole presentation is this peripheral, we do perform coronary angio because we had a study in which 60% their association between peripheral and coronaries, whose sole presentation was only peripheral arterial disease.
The other thing is, you know, he's not going to die in life as compared to the coronary.
So
That's a big plus.
that's right.
This is
So-
more on the easier side
Next move to,
for
so
the performer and the patient as well.
I think we should move to the
But
next
he would
session
not be
because
cured as
we are
well.
running short of time.
He would not be cured as well.
So our next speaker will be Sir Dr. Asim Javed, a very famous person. He don't need any introduction, and he has done a remarkable work of stroke intervention in Pakistan. So I would request Dr. Asim to come on the stage. Evolution of stroke team and treatment in the future, insight from the AI and emerging technologies. Dr. Asim Javed.
Bismillah ar-Rahman ar-Rahim. Thank you very much. But before I go on to my talk, I think there's a very important concept on this peripheral interventions that I would like to clarify. We've got some juniors sitting at the back as well. Dr. Masood is sitting here. So I was listening to his talk in very early days when I was thinking of starting peripheral interventions. And the concept that I learned from him is very important for the juniors also to learn. So जब आप किसी की भी पेरिफेरल आर्टीरियल डिजीज है और अगर पेशेंट की आप देखें यहाँ पे एम्पुटेशन करते हैं, जिस लेवल से आर्टरी बंद है जब तक वहां से एम्पुटेशन नहीं होगी तो जो जख्म बन रहा है वो भी ठीक नहीं होना. सो या तो आप आर्टरी को खोल के उस लेवल तक ले जाएं, जितना नीचे आप ले जाएंगे वहां पे जब आप एम्पुटेशन करेंगे तो उसमें ब्लड पहुंचेगा तो जख्म ने ठीक होना है. सो लेवल ऑफ एम्पुटेशन को आप नीचे लेके जाते हैं जितना आप एंजियोप्लास्टी करके फ्लो को बहाल करते जाएंगे. सो ये बड़ा इंपॉर्टेंट है कि डायरेक्ट एम्पुटेशन पे जंप ना किया जाए एंड फ्लो को जितना नीचे तक बहाल कर सकते हैं उसको एस्टैब्लिश किया जाए. So since Dr. Masood is sitting here, so thank you very much, sir. You always enlightened us with your knowledge and experience. So,
sorry, Dr. Asim, sorry, just.
sir,
What is the cutting line? The thing you are saying now
Sir-
between the amputation and between going for your procedure before the amputation. What is the bottom last line? Where you draw the line?
there is no last line as such. किसी की अगर टोज भी खाली गैंग्रीन हुआ है और आप अगर उसका फ्लो एस्टेब्लिश करते हैं, कोलैटरल्स पे चल रहा है, जैसा भी आप जितना उसका फ्लो एस्टेब्लिश कर देंगे तो जितना लिमिटेड गैंग्रीन था आपका गैंग्रीन उधर ही लिमिट हो जाएगा. ज़्यादा से ज़्यादा वो हो सकता है ऑटो एम्पुटेट उतना हो जाए या उसको एम्पुटेट करना पड़े, लेकिन वो जख्म तभी ठीक होगा अगर उस पॉइंट तक फ्लो एस्टेब्लिश है.
You mean to say that every patient who may be going for amputation should have this procedure first?
शुड हैव इमेजिंग डन टू सी के उसके अंदर क्या चीज की जा सकती है. क्या एंजियोप्लास्टी के जरिए हम कर सकते हैं फ्लो एस्टेब्लिश या वैस्कुलर सर्जन कर सकता है ग्राफ्टिंग. अगर दोनों चीजें नहीं हो सकती तो फिर किस लेवल पे आर्टरी बंद है जिस लेवल से फिर आपको एम्पुटेट करना पड़ेगा. अगर आर्टरी एसएफए के लेवल पे अबव नहीं बंद है और एक सर्जन पेशेंट का पैर एम्पुटेट कर देता है तो वो पैर का जख्म तो ठीक नहीं होगा, उधर फ्लो नहीं पहुंच रहा है. आर्टरी तो बंद है एसएफए अबव नी लेवल के ऊपर, या तो फिर वो अबव नी लेवल से एम्पुटेट करेगा तो फिर ही जख्म ठीक होगा. एम आई राइट सर मसूद?
gangrene starts distally. So if you mistakenly amputate the distal part, you have to amputate again after a few weeks, bit more proximal. It's called Gundari amputation. So you avoid Gundari amputation, as he says. First of all, try to see where the lesion is. If the lesion is proximal, go for it. Otherwise, it will never heal. Never heal.
So these patients always need at least a CT angiogram.
So imaging assessment is important.
So coming back to my topic, since my time is running, I'll try to be as quick as possible. So stroke is a leading cause of death and disability worldwide. Globally, every fourth person aged over 25 years will suffer a stroke in their lifetime. 2/3 of stroke patients die or have moderate to severe disability, and only 1/3 are lucky enough to live with minor disability or recover fully. So the objective given to me today is to explore the historical evolution and how AI is revolutionizing stroke care. So in the 5th century, Hippocrates, the father of medicine, was the first to recognize stroke. And then it was 1658 when Dr. Johann Jacobs of Switzerland, he distinguished first time between ischemic and hemorrhagic strokes based on postmortem examination. 1807, Dr. Amos performed the first carotid artery surgery in USA to prevent stroke. So to prevent stroke, it was 1807 when they were working on it. Therapy of stroke is now actually coming in. So there is a big gap in between. Now, 1927, Antonio Egas used X-ray technology to produce the first image of cerebral arteries in a living person. And then 1970s, everything started changing with CT scan technology coming in. So the first revolution in stroke treatment came in 1995 when IV alteplase got US FDA approval for use in stroke. But we do know that with thrombolytics, there is time constraint. There are so many contraindications to thrombolysis, and the most important concept that we must understand is that these thrombolytics in stroke are effective more in the distal and small vessels of the brain. But if you got a large artery of the brain blocked, then the TPA is not that effective as a sole treatment. So if you look here at the ICA, if the clot is there, the effectiveness of IV TPA alone would be only 4 to 8%. So that means we need to do something more, and this was realized very early on. So this was 2000 when this case report was published. People were trying to remove clots from the brain, so they used a coronary microcatheter, a micro snare to remove a clot, which they successfully did and established flow. And since then they've been trying. So in 2004 came the Mercy device, wasn't that very successful. So then came Solitaire AB. Now this stent was actually meant for stent assisted coiling of cerebral aneurysms. But then they realized that this could remove clot as well. And then endovascular treatment started evolving. Mercy, Penumbra, stent for stroke, and now the current generation is the stent retrievers. 2015 was a game changer. This was the second revolution in stroke treatment with all of these trials coming in. And then mechanical thrombectomy for large vessel occlusion got a class 1A recommendation. So this was within the first 6 hours. But then, based on Dawn and Diffuse 3 trials, the time window for mechanical thrombectomy got extended from 6 to 24 hours. Now what's important? Time is brain. If we can reopen a blocked brain artery within 2 hours, recovery rate is 90%. The West really realizes the importance. So what they're doing now is, they are now installing mobile CT scanners in these ambulances. So once they receive a call from home that the patient has collapsed or symptoms given from the family are matching that of a stroke patient, they would send one of these ambulances to the house so that on the way they will get a CT scan done, and they will send that CT scan to the hospital, and they will guide them where this patient needs to be taken, either neurosurgery or a center for mechanical thrombectomy. Now, artificial intelligence is very quickly coming in and changing the whole landscape. Image analysis, clinical decision support, workflow optimization, prognostication, and outcome prediction. It's playing its role in all of these aspects. Now, many AI applications are there. What they are doing now is this application within 2 minutes gives us the complete analysis of the stroke patient. It analyzes the plain CT brain, tells us if there is a bleed or not. If it is ischemic, it immediately analyzes the CT angiogram, exactly localizes where the clot is and which artery is blocked. It will show you. It then immediately analyzes the CT perfusion scan and tells us exactly how much brain is dead, how much brain is salvageable. At the end, it clearly writes down this patient is a candidate for mechanical thrombectomy, or it will say this patient is not a candidate for mechanical thrombectomy. And these images that you see here and this decision comes on our mobiles or on the email addresses of the whole on-call team that for that day. They will all receive these messages, and everything is done within 2 minutes by AI. So you get a good support with this. So RIC and NICVD both have these AI applications available to us now. Then many AI applications are there, Methinks, Viz AI, Rapid AI, Sina. Methinks is now getting more advanced. What they are now doing is, instead of doing a CT angiogram, the AI is going to tell us based on a plain non-contrast CT, it's going to tell us that this ischemic stroke has a large vessel occlusion or it does not have a large vessel occlusion. So again, this is AI, and they are about to come out with it. Robots are being used in different therapeutics, so it's also coming into neuroendovascular. So the issue in neuroendovascular is that we have a lot of tortuosities in the cerebral circulation. So the routine wires that we use, the robotic arm when tried had a difficulty taking those wires up. So now they are coming up with these magnetic wires. So they have a magnetic tip, and what they do is the robot is guiding these wires in. It's going to do the whole intervention with, of course, controls with the operator. But then at the head end of the patient, this magnetic arm is there. And this magnetic arm, you can easily move, change, and this is going to guide the wire tip to go in which direction and take the bend in which direction. So with this, they are solving this problem of the cerebral tortuosities. And now this is my last slide, and this is something very interesting and will change the whole landscape of stroke intervention if it comes into play. So histotripsy. Histotripsy is already being used for treating cancer patients. What it does is, you have ultrasound waves that create micro bubbles within the clot, and as they expand and collapse, they mechanically break down the tissue or the clot wherever it is used. So they are trying this now on stroke. So the way it works is that, sorry, let me just play this video for you. ये वीडियो प्ले कर सकते हैं जी, उधर से आप कर सकते हैं, इसके ऊपर प्ले कर दें अगर सिर्फ, चलें, thank you very much. So you see this machine coming forward. So it's a mobile machine like an ultrasound. So patient has to be intubated under general anesthesia so that it does not move the head position. So this machine comes on, patient's head comes in between, and it will start doing a transcranial Doppler with the help of AI. So AI is going to start this transcranial Doppler. It's going to detect through transcranial Doppler where exactly the clot is sitting, which artery is blocked, and once it detects that the large vessel is occluded, then the transcranial Doppler will stop emitting the Doppler waves, and instead it will start doing histotripsy. What histotripsy will do is, it will hit the clot, and the clot is going to break down and melt away. And in order to prevent the clot from distal embolization, it is going to hit from both sides. So from left and right, one side is going to hit the lower side of the clot, the other side is going to hit the upper side of the clot, and the clot in between is going to disintegrate and just, it's going to move away. And this will really change the way stroke is being treated, because currently you don't have neurointerventionists even in developed world. you lack them. But once this machine is available, it will be available all over the world in every center, and stroke can easily be treated. But currently, it's been successfully tested in the 3D flow models, and nowadays it's undergoing animal trials in Gates Vascular Institute with Dr. Adnan Siddiqui and his team. They are doing the animal trials on it. But if this technology comes ahead, I think this will be a giant leap in stroke treatment. So in conclusion, stroke care has evolved from sportive therapy to time-critical interventions. Mechanical thrombectomy has revolutionized outcomes for LVO strokes. AI is transforming stroke care through rapid diagnostics and improved workflows to therapeutic interventions. Thank you very much.
Excellent presentation, Asim. May I ask you, you have shown us the ideal situation. What's your modus operandi, how your unit is working at the moment?
Sir, it's based on teamwork. Radiology and neurology do the case selection. We've got the AI support available to us. So AI is there to help them for the case selection. Once they select the case, they involve the interventionist to do the intervention in the cath lab. After the intervention, the patient goes back to the neurology team and they take care of the patient in the wards and the follow-up.
And how do you make a choice between thrombectomy, mechanical or thrombolysis?
So it is time-based. If the patient is within the first 4.5 hours of symptom onset, he qualifies for IVL teplase. And if on CT angio he has a large vessel occlusion, then he qualifies for both. He's within 4.5 hours, or then he qualifies for both IVL teplase and mechanical thrombectomy. Both need to be done simultaneously. If it's a small vessel occlusion, patient is within 4.5 hours, then he only gets IVL teplase. If he's beyond 4.5 hours, then he does not get IVL teplase, and for a large vessel occlusion, he gets mechanical thrombectomy alone.
And what's the success rate so far in your practice?
So we've got 10 interventionists who do intervention in RIC. Angiographic success rate would be around, I would say, 75 to 80%. Clinical outcome, patient going back to normal functional life, is around 35 to 40%.
Dr. Asim, excellent presentation. What is the role of protection devices, and are you using any?
Role of?
Protection devices.
Sir, role of protection devices is more when we do the elective carotid interventions rather than stroke, because if the cerebral arteries are blocked, then there is no role of it. If it's a carotid that is blocked and the cerebral arteries are patent and the patient presents with acute stroke, then while doing intervening on that carotid, we do use these protection devices.
Any difference in the management of posterior circulation stroke as compared to the anterior?
So there are a few technical differences, but otherwise the time criteria is the same.
Thank you very much.
Thank you, sir.
Thank you, Dr. Asim. Excellent talk. So our next speaker will be Dr. Abidullah. Abidullah is here? He is not here?
Assalamu alaikum. Salam bhai, I'm on Zoom.
Acha, sir, thank you very much, sir, you are here. Thank you very much. Right. I was just skipping you, but Abdullah is here. Sir, so Dr. Abdullah will tell us of multi-modality imaging on structural heart disease. Sir, please carry on. Start. Dr.
Assalamu alaikum, everyone. Thank you very much.
In Peshawar Institute of Cardiology. And
thank you very much for the invite. Sorry I couldn't have been there in person because of some personal commitments, but it's always an honor to be presenting in a meeting like this. So I'm going to be talking about the multimodality imaging in the structural heart interventions. We all know that the structural heart interventions, it's constantly evolving. There have been improvements in technology, procedural techniques, and much more critically in the imaging guiding these procedures. And if we look at the spectrum of the structural heart interventions, they range from the commoner, like the TAVI, MitraClip, ACE, DVs, declosures, so on and so forth. And the imaging, it plays a critical and central role in each one of them, and it guides every stage of the patient care. So if we look at the different stages, so in the pre-procedural imaging, it's very important to have a proper transthoracic echo, a TEE, and a cardiac CT. And once a need is identified for an intervention, then the anatomical suitability, the device size and type, and the vascular access strategy. Beyond that, once the patient is selected for an intervention, then it's usually the combination of the fluoroscopy and the echocardiography, and it's the 3D echocardiography and the recent advancements of them which have revolutionized the structural heart interventions. And if we look at the different interventions, there are different modalities for each one of them. So for a TAVI, majority of us now know that it's the CT, which is essential for the pre-procedural imaging. When we come to the intra-procedural imaging, it's the fluoroscopy, which is the cornerstone. The TE has very limited role there because majority of these are now done under conscious sedation. If you compare that to the other procedures like the mitral clip and the left atrial appendage occlusion, they are mostly TEE, the 3D TEE guided, and I'll be giving a couple of examples of those. TAVI we are all aware of. CT is a cornerstone for access site, for annular dimensions, and then for the coronary ostia and their height to have an appropriate and proper procedure. But I want to talk about two other procedures. One of them rather simple one. The second one will be a more complex one. Paravalvular leaks, not an uncommon problem. Even in the developed countries, 2 to 10% of AVRs, 7 to 17% of MVR might have significant PVL, and these patients can have serious clinical consequences. The surgeons, understandably, they are not very keen on the redo surgery because the mortality can be as high as up to 37%. So that's why we need to have alternative management plans for these. And the cardiologists are going to be more and more involved in these. I will present the first case of a 49-year-old gentleman. He had a mechanical aortic valve replacement, which was a Medtronic Hall, for severe aortic regurgitation secondary to a bicuspid aortic valve. He was developing more shortness of breath over the next 2 years, and he had significant paravalvular leak. He was referred to us from Lahore. We did a transesophageal echocardiography on him, and if I can point to the area, so interiorly, we can see that there is a gap next to the implanted valve, and that's where the paravalvular leak was coming from. We thought this patient to be a candidate for percutaneous closure. We brought the patient to the cath lab. So in the first image, if we look at the fluoroscopy, I think everyone will appreciate that we can see the tilting disc of the AVR, but it's very difficult to appreciate where the PVL is and where exactly the leak is coming from. But we can appreciate that much more clearly on a transesophageal echocardiography. And again, under the guidance of the TEE, we can cross this space with either a glider wire or with a normal 035 wire. And the 035 wire actually has a distinct advantage here because it's much more visible on the TEE, and it can guide the procedure there. So once we are in an appropriate space for deployment of the device. The device is then put again under the TE guidance, and once we are happy that we are in the proper place and it's going to seal the leak, then we deploy, and we can see on the TE that the paravalvular leak is appropriately closed. So this was a rather simpler use of the TE in a paravalvular leak. I would like to talk a bit more about the mitral clip, which is a truly TE guided and a fluoroscopy assisted. And if I want to push it, I might say that you can do a mitral clip with a minimal of fluoroscopy. Even someone might say that you can do it even without fluoroscopy, which is a step too far. So if you look at the selection criteria for patients to consider the mitral clip, they are based on the Everest 2 trial, moderate to severe mitral regurgitation, pathology ideally in the A2P2 area, but now the operators are pushing it more and more. Coaptation length of more than 2 millimeter with a coaptation depth of less than 11 millimeter, and a flail gap of less than 10 millimeter with a width of less than 15 millimeter. So each one of these need a very good echo assessment even before we consider a patient for mitral clip. So once a favorable anatomy is identified, then the patient undergoes a TE and it allows a detailed assessment for the procedure. The preoperative assessment, basically, there are three views on the TE, which involves the 3D TE as well. So the main view is a bicommissural, which is explained to an L view, T view. I will show that in a bit. The second view is a bicable view with an explained to reverse aortic valve short axis, and this is for the optimum septal puncture spot. The third view, which is very important, is a four-chamber view for the height of the puncture. So once the patient comes to the cath lab, we reassess the mitral apparatus. We look at the mitral regurgitation, we look at the left atrium and the left atrial appendage for any thrombus, and we document any presence or absence of pericardial effusion. So as well, I was mentioning earlier, the main view is the bicommissural view with the cursor across the mitral valve, and in the X-plane view, we'll have an L view, T view, and we put color on that, which shows an eccentric jet of mitral regurgitation. We assess the mitral valve further by sweeping from medial to lateral. So the cursor is taken from the medial to the central and then to the lateral side, and we can assess each and every part of the mitral valve. So once we have done that, then we measure the length of both the leaflets, and we look at the fly gap as well and decide on the appropriate mitral clip size. Beyond that, then we come to the interatrial septum. I just want to show the baseline 3D. So this is the 3D, which is a clock face. It is Z-rotated to put the aortic valve in the interior position. Then the commissures should be at the 10 and 2 o'clock. And we put color on that, and we can very clearly see the mitral regurgitation, and that will be the area that we will be targeting with our mitral clip. The interatrial septum, I know that the experienced operators, they would do it fluoroscopically, but with these interventions, it's very important to guide these with a TE because the anatomical landmarks cannot be seen on fluoroscopy. And again, it's the position of the septal puncture which is important to be very accurate. And I will just briefly show. So it's a bicable view with the inferior vena cava and the superior vena cava, which is explained to a aortic short axis view, and that's where we do the puncture. In the four-chamber view, we want the puncture height to be at least 35 millimeter, 35 to 40 millimeter, depending on the pathology of the mitral regurgitation. I will just skip these and go directly to when the puncture is done. So we do the puncture under the TE guidance. The needle is brought back from the SVC till it falls in the fossa, and then we double check in the four-chamber view to make sure that our height is appropriate. Once the puncture is done, then it's very important to follow the wire, which is the stiff wire, and we try to avoid the left atrial appendage. The wire goes into the left upper pulmonary vein, and then the mitral clip itself can be delivered over this wire. So the mitral clip, again, is brought under the TE guidance. It is taken across the mitral valve. The position is checked in relation to the commissures of the mitral valve, and then it is deployed Once we are happy with the position of the mitral valve and we are happy that the mitral regurgitation is reduced, which is checked again in the 3D. So this was a clock phase that I was showing earlier. Again, the aortic valve is interior. We want to make sure that the commissures are at 10 and 2 o'clock, and the mitral clip is nicely across the gap in the mitral valve. We again check that there is a nice bridge across the mitral valve, that the mitral valve leaflets are taut, and we check that the mitral regurgitation has improved. Once we are happy with the position, then the mitral clip is released again under the TE guidance, and the guide is removed. So this will complete our procedure, but before we take out the TE probe, we want to make sure that there is no significant complication. If there is an arterial septal defect, it should be assessed, and if need be, it should be closed at that time. So I would finish by just putting a few take-home messages. I think that cardiac imaging is the cornerstone of the structural heart interventions. There are different modalities, and it's essential for the operators to be able to perform and analyze the images themselves. Apart from the CT, which is essential for the TAVI, the transesophageal echocardiography plays a central role in each and every one of these procedures. And I think with these procedures becoming more commonplace, there is a need for standardized training. Thank you very much.
Thank you, Dr. Abdullah. Very interesting, very informative talk, and thank you very much. Thank you very much. So now I will request
Thank you.
Dr. Asad. Dr. Asad Akbar is here. You are saying that he is not here. He is here, yeah. So, Taver versus Sever. By
So last year, last year this was given by Ali, and we created an argument between surgeons and us. So this year we love surgeons, but still we are better. So this is what I'm going to say at the start, and then we'll see if we have a discussion afterwards. Can we have our slides, please? क्या पीछे से करोगे या मैं इधर से करूँगा? वो क्लिक नहीं हो रहा ना. सर
सर आपसे पर्सनल क्वेश्चन
इधर सबके सामने
हाजी है या अल हाज है
सर हाजी हाजी सर ये आपका जो घर है
बड़ी बड़ी मुबारक हो सर
थैंक यू सर जज़ाक क्या हुआ है
अरुण पूछ रहा है कि इंडिकेशन क्या थी आपकी आज करने की?
अगर जितनी देर ये सॉर्ट आउट हो रहा है, अगर अली रजा की टॉक है तो वो चला दीजिए.
हाँ, ये मैं कहने लगा था. हाँ. We can call the next
अली
speaker.
रजा. Okay.
Ali Raza? So our slide is not. No, no, you should come on the stage. Slide को मसला करे तो मेरा खरा. कौन जीता? Surgeons के तुम No, no, I will request Dr. Ali Raza to come on the stage and he will tell us about the lifetime management of the TB patients. He is a very famous person and he is doing a lot to spread TB across the Pakistan. He is also a teacher and a friend. Thank you.
Thank you.
Come on.
Thank you so much for a very kind introduction. Lifetime management for TAVI. We know that the scope of TAVI is expanding all over the world, and even in the US data recently, it has shown that aortic stenosis, single AVRs has gone actually down and the TAVI procedures have gone up. So because we will be moving more towards the younger patients as per the ACC guidelines, it's around 65 years of age. So they consider, because they live longer, so they consider whether many things for the lifetimes. There are a few things which I'm going to cover today, which is valve selection, coronary access, and conduction management. So when you're planning for younger patients and older patients, usually the outcomes you have to look are different. For younger patients, usually you look for hemodynamic and PPM mismatches, durability, coronary access, and future valve in valve. Whereas in older patients, you look for immediate outcomes, which is the mortality, stroke, quality of life, or any conduction disturbances. Although conduction disturbances are looked at for younger patients as well. So procedural consideration, we have limited options here, but you have to look for where you have got availabilities for balloon versus self-expanding valves. Each have got advantages and disadvantages, so you have to look into those. First thing, coronary arteries. So we know that there is a lot of prevalence of coronary artery disease with TAVI patients. And whether you choose PCI before TAVI or after TAVI, that depends on you. Although Abdul Wahab from Germany, he's a guy who works there, found that there's no significant difference if you do it either way. And there is another, which is the 2021 publication, which showed that coronary artery disease is prevalent and it's independently associated with mortality as well. So you have to always think about that. Different criteria for coronary access. Next slide, please. It's not changing. Can you change the slide to the next one? Excellent. Okay, this one. So if you look, there are different criteria to look for which one are high risk patients, which one are low risk patients. The one on your left side is slightly complex, but the Jafar had simplified it, and he thinks that if there is a cusp height more than the coronary and VTC is less than 4, and the leaflet calcium is also different, then you have lesser chances of having any coronary obstructions. Although if your coronary osteas are very low, then the risk is quite high of obstructing them, especially considering that the STJ sections are very low as well. Once you have that, then you have to look for the valve, which valve you have to do and how much of the commissural alignment, because you need that in order for future access to the TAVIs as well. If you see if the coronary osteas are less than these markers, I don't know if I can point towards it, but the ones, yeah, so it's not working. Anyway, so the bottom line, this red part, is basically the skirt of each valves. And if the skirt, the ostium is below the skirt and there is commissure in front of it, then usually your risk of coronary obstruction is very high. Low frame heights, which is the sapiens on your right side of the screen there, is basically the valves which are balloon expandable. They've got short stents, and usually they are better for accessing the coronary arteries. This is our case which we did, and if you see, there will be a leaflet coming up once it inflates completely. And if you see, you can see in front of that that white segment in front of that coronary artery is the calcium bit. So once you deploy the valve, you will be very sure that this block, because STJs are very low, and that white bit is going to block your ostia. So for these patients, you have to consider doing in future any accesses, and we did actually chimney for this patient. Even in the CT scan analysis is very important. If you see the coronary ostium is very low for those as well. For future conduction defects, next slide, it's still not changing. Oh yeah, okay. So, I don't know, they want to finish it, I think. Oh, here we go. Okay, so left bundle branch block conduction defects, very important, because once you get conduction defects, it associates your outcome as well. And if there is a left bundle branch block, so that you can be associated with progressive LV dilatation. And if even in partner 2 studies, even if they were not like with permanent pacemaker, left bundle branch block affects your outcome. And especially a QRS duration of more than 160 or equal to 160 post procedure is going to be a bit problematic. Permanent pacemaker again demonstrated that pacing related LV dysfunction in post-TAVI patients, and also that PPM also delays the recovery of the left ventricular ejection fraction. So you have to make sure that you select the valves and in correct positions where you don't get these conduction defects. These are the comparison between different valves for showing pacemaker incidence. If you see that Medtronic has got a lot of incidence in it, which is the core valve initially was 25%, although with the cusp overlap technique they have reduced as well. These other valves are coming at the moment as well. We have got, I think in Pakistan soon we will have Allegra probably coming as well, which is biosensors are going to bring those. And the other one is the Hydra valve as well. They've got their own advantages and disadvantages as well, so you have to know about the valve frame before you deploy it. Future, again, if you're doing it in younger patients, they will need another valve in future, and for that you need to consider that a TAVI in TAVI is an option, or whether you do a surgical valve and the TAVI later on, it's up to you guys. But again, these have shown that these are feasible. Even a CE approval has happened to Medtronic recently for a valve in valve. Again, for redo TAVI, you have to look at the considerations, which valve goes first. Usually, internationally, you do a short frame valve first, which is the Sapien, and then followed by a high frame, tall frame, which is the self-expandable Medtronic valve. And these are different levels where you deploy those. So it says that if the outflow of the S3 is at the level of the 4th node at evolute, there's a 80% chance that you are okay. Whereas an evolute in evolute is pretty much a disastrous type of a situation. Valve in valve again, so once you're doing valve in valve, there's an app there on valve in valve aortic, which is you can download from Apple and Google as well, which is very good because it tells you the trifecta about the mitral flow and everyone, which one you can crack, which you can't crack. Trifecta you can't crack, I think the rest you can crack. And the technique is usually you attach an indiflator and a pressure syringe to it, and you do it. Some people do it before procedure. I think preferably do it after procedure because it can protect the AR, although it can damage your leaflets. So it's a choice between which the clinician makes. But these studies have shown that you can do it. Basilica is again another technique which can be used in order to protect your coronaries. And there is a lot of comparison data for Basilica with chimney. Basilica comes out to be very safe in experienced hands. Again, you have to also look for bioprosthetic valve dysfunction. There are different kinds of valve dysfunction: structural, which is within the valve; non-structural valve deterioration, which is like paravalvular leaks or around the valve; and then thrombosis and endocarditis and other features which you have to look for future. Comparison with SAVR and TAVI, durability is pretty much good for TAVI. There is data 10 years now available which shows the structural valve deterioration is higher in SAVR patients than in TAVI patients. They argue that this was trifecta in mitral flow, but then TAVI people argue that this was core valve in its early phases. So there's a lot of debate about these presentation of 10 years data. Structural valve deterioration, again, comparison of different, and if you see all these trials which were done, its TAVI comes out to be quite good actually. And even if it is not good in some of it, it is equivalent to the structural valve as well. So all these trials show that you can do TAVI for these patients and plan for future as well. Imaging for the lifetime management, again, HALT is a phenomena where is hypertension. It happens if there is a thrombus formation within the leaflets, it can destroy your leaflet. So it's better to identify it, and you can check it with the echo gradients and also with the CT scan measurements, which can you get hypertenuated pictures like this. Antithrombotic management, this is post-TAVI, you have to give single antiplatelet majority of the cases, unless and until you check the gradients later on and they've got a bit of increased gradient or any halt on their CT scans, then you can switch to the anticoagulation as well. So summary is that TAVI is previously 80 years old or 85 years old. Getting TAVI is different from 60, 65 years old, 70 years old, or fit people having TAVI, because you have to think and tailor their treatment according to their requirement. Thank you so much.
Wonderful talk.
Well
Just one question. Do you consider, or is it becoming in the guidelines to use it as a bailout procedure in a stage 4 kind of patient in the 20s who is a very high surgical case? So is it going to be in the guidelines, or have you ever used it?
You mean, what's the, sorry, you mean these young ones?
As a bailout procedure?
Oh, younger patients, yes.
Yeah.
So I have used it, one patient who had a coarctation being done, and then coarctation, he collapsed, he had severe AS, so that was a miscalculation. I think the severe AS should be treated before coarctation, so the patient collapsed and he was pretty much a CPR. In CPR we put the TAVI for him and he did okay, but then the problem is now that he was 32 or 33, something like that. And the plan was to explant that valve later on, so we thought that we'll do a bailout, explant it in the next few weeks or months once he gets that, but he had such a traumatic event that he doesn't want any procedure now. So now he has got a evolute valve in there which is going to run for probably 10, 12, 15 years, and after that, but at least he was dead, so he was CPR, it was, so he's still happy with it.
Ali Raza, is this cost covered by health card or?
So that's a very technical question. There's a very complex formula which I have already taught RIC as well. So it works in a different way, sir. I think cost is not covered by health card. Recently, what happens that there are sources from which you can cover it, but it's a hidden formula. I know that Jabbar is sitting here. I don't want to say it out loud because he will hear it then. I'm joking.
So some sort of private arrangement.
No, it's not a private-ish because we do TAVIs. RIC does it free pretty much for patients. They do it private as well, and PIC does it the same way. They try to cover the cost through some way or the other. I didn't answer your question.
Thank you.
On purpose.
I'll find out.
Contribution लेते हैं, बाकी अपने करते हैं आपके पास. Thank you, Dr. Ali Raza. Very beautiful talk. So, अब slide चलना शुरू होगी मेरे ख्याल. So now I will require Dr. Asad Akbar to come on the stage. He will tell us about the TAVR versus SAVR. What does the data shows? It's a very interesting topic. चल गई यार कि नहीं?
चल तो ये इन पे चल रही है ऊपर में.
यार नेक आदमी हज करके आए अभी स्लाइड में चल रही है.
तो मेरे ख्याल में मैंने बुराई कर दी सर्जन की.
नहीं नहीं.
वीडियो तक आए तो सही.
नहीं आपका अपना नहीं है वो वाला जिसपे.
मंदेशा साहब आप आ जाएं. मीनवाइल ये फिर नहीं चल रहा.
इसके बाद नहीं सर आपके बाद आएगी.
ये आगे पीछे इसी से ही होगा. आए तो सही है. अच्छा तो purpose of our talk is just to have a quick look at how did we come to this point in time where we are discussing TAVR as first line therapy even in sort of younger patients. Aortic stenosis, we won't go through the definition. We know what aortic stenosis, severe aortic stenosis is. For the purpose of all the trials, these were the three criteria that had to be fulfilled, at least for the FDA trials. A valve area had to be less than 1, mean gradient had to be more than 40, or the peak velocity had to be more than 4 meters per second. This is Eugene Braunwald's paper from Circulation 1968, and this data still holds true, that as long as these patients with severe aortic stenosis are asymptomatic, their life expectancy is the same as anybody who does not have aortic stenosis. As soon as they develop symptoms, the life expectancy falls down rapidly. Depending on which symptom they are presenting to you with, you can actually predict what sort of life expectancy you're looking at. If angina is the main presenting symptom, then 50% of them will be dead by 5 years. But if they came into you with heart failure, then there is a 50% mortality in 2 years. We skip through these. So SAVR and TAVR and then balloon aortic valvuloplasty used to be done pretty frequently. Even when I was training in 2015 as a fellow, we used to do about 400 BAVs every year. And when I was leaving Sinai in 2019, we were only doing 100 of them because everybody, we got all these indications for intermediate risk and everyone. So first TAVR was done by Anderson up in Russia. Nobody gives him credit for it, but he was the one who actually came up with this idea of a balloon expandable valve that he implanted in a pig. The person we are more aware of is Alan Kribbe, who passed away recently, and he decided that we use the calcium that is present on the native aortic annulus, and we use that to hold the valve in its place, and once the balloon is inflated. This is the first case that he did, surgically inoperable patient who was done in conscious sedation, and he was up in 15 minutes. So overall, when you look at these patients, surgeons have this score which is called the STS score, and based on that they tell the patient if they are low risk, intermediate risk or high risk. This risk profile essentially means, based on certain risk criteria, that what is the chance of them dying after a surgical aortic valve replacement within the first 1 month of their procedure. So we have data for TAVR across all these, across this entire spectrum. For futile aortic stenosis risk cases, which have a 50% or more mortality, we don't have a direct data, but we have the data from partner 1B, where patients who were considered futile risk, where, so futile risk means they were not given the option of surgical valve replacement. All they had was a TAVR versus medical therapy. And we know, even in that particular cohort, which would have been a futile risk, would have died within a month, even there was a significant improvement in their life expectancy once they underwent TAVR. For the extreme risk cases, where the mortality risk was 15 to 50%, we have 2 US-based trials, Partner 1B and the core valve trial. For the partner trial, we saw a 20% reduced risk of death with TAVR versus standard therapy. Again, these are extreme risk cases, which, so the standard therapy for extreme risk cases is also medical therapy. So TAVR versus standard medical therapy shows a 20% reduction in all-cause mortality, and similar result was shown with the core valve. For the high-risk patients, this is where we started comparing them with actual surgical aortic valve replacement. Again, 2 US-based trials were done, Partner 1A and pivotal core valve. For the partner trial, we saw there was no significant difference, but at least it proved that it was non-inferior. For the only thing which was sort of worse with TAVR was the risk of stroke. At 1 year and 2 years, there was slightly higher risk of stroke if balloon expandable valve was used for TAVR versus surgical aortic valve replacement. This particular signal was not seen with core valve. This is a significant reduction in mortality, and they got a significant score for superiority over surgical valve replacement as well, and the risk of stroke was lower. Then we come to the intermediate risk cohort with an STS score of 3.4 to 8 to 10, and again 2 trials were completed, Partner 2A and the CERTAVI trial. For the Partner 2A with the balloon expandable sapien valve, we had a significant improved all-cause mortality with the TAVR versus surgical aortic valve replacement. A similar result was shown with the core valve, which was called the CERTAVI trial, and we had no major difference. And it was so for the low risk patients, these are probably the most recent ones. STS mortality risk of less than 3%. So remember, less than 3% means surgery all had their data for 20 or 30 years. For somebody who is doing TAVRs, for somebody who has at that sort of a low risk, 1 stroke in your first few patients means that you are going to cripple the data for the rest of the country actually. So 1 trial was done out of US, which is a NOTION trial, and then there were 2 trials done in US. NOTION trial was done basically in Europe. Again, the one drawback with the TAVR in this cohort was the rate of pacemaker implant. 38% pacemaker implant rate was seen in NOTION trial for these patients. This is low risk again. For the US-based trials, Partner 3 showed a significant difference in terms of all-cause mortality and stroke when compared to surgical aortic valve replacement. And for the Evolute low risk trial, which is the self-expanding valve, we saw that there was no difference. So TAVR was as good as a surgical valve replacement in this particular patient cohort. So if you look at it, we have data across this entire spectrum of risk scores, right from low risk patients where you have a STS score of less than 3% to a patient who has an STS score of 50%. TAVR does better than standard therapy, which is either surgical valve replacement or medical therapy in case of extreme risk patients. These were the guidelines in 2014. They were updated in 2017, where you see intermediate risk cohort also getting a 2A indication for TAVR. And then we had a latest update in 2022. I forgot to put that in. And you have low risk patients coming in, which are being given this indication as well. The answer to your question regarding young patients being given this option or not, the trials, the US-based trials were done in low-risk cohort on patients aged 65 and above. And the European ones were even older. They were like 70 or 75 and above. So I don't think there will ever be a guideline which will tell you that you can do it in a 20-year-old. They have to be done on case-by-case basis. We have a few new indications. This is just an example of a balloon expandable valve. We have no time left. But I'll just show you, maybe we can leave it, because this is a surgical valve that was replaced a few years ago, had a coaptation gap as well as stenosis. This is a valve-in-valve case. We measure, Ali elaborated all these numbers. You do these numbers to make sure there is a very low risk of coronary occlusion. And then this is a slide from that valve-in-valve app that you can download, and that tells you which one will be the suitable valve for them. This is just a device to protect them from embolization and stroke. This is how the valves look like. We crossed it. This is just after core valve, and there was no gradient. I think the time is gone, so we'll finish it here. Thank you.
Continuing on the same question, I think it's an evolving process. You started with 75 years, that was the cutoff. Then the cutoff was gradually lowered. So maybe people are hesitant or afraid to talk about that thing which I was saying. Maybe in the next future, maybe in 3 years, 4 years, 5 years, we would be talking. Because you are already talking about valve-in-valve, then why are you talking about that if you are not going to utilize that in situations?
Yeah. So as Ali said as well, the patients in which we do end up doing this, we would do something that mimics a surgical valve more closely than a TAVR valve. So we do a short frame valve first, a sapien valve. Pakistan, we don't have those available. They were available and then they went out of market. So, but if you put the first valve as their core valve, issue will be putting in another core valve in them. We don't know if we'll ever get them those shorter frame valves in Pakistan. So it's very hard to offer it to people. Last comment. I get a lot of referrals from patients who, from parents with young females. Pakistan is a disaster in terms of a young girl with an 18-year-old girl, bicuspid aortic valve, could have done TAVR in her, but what's the lifespan we are looking at? Only 8 to 10 years. But obviously the parents' worries are who is going to marry her. And that girl ended up with a metallic valve, and she stopped taking her warfarin. Luckily she survived it because aortic valve is obviously a high flow area, but that's obviously a dilemma in our society, that if something like a short frame valve becomes available, it might give us more options.
Thank you.
Thank you.
Thank you very much, Dr. Sadakpar. So now I will request Professor Akhtar Ali Bandesha. He is the last speaker. He will tell us about the hypertrophic cardiomyopathy in adults, guidelines and rundown. Sir, Professor Akhtar Ali Bandesha, sir. Thank you, sir.
Bismillahirrahmanirrahim. Thank you very much, Dr. Abdussalam and chairpersons and colleagues. My talk is about the management of hypertrophic cardiomyopathy, and we know that hypertrophic cardiomyopathy is a relatively common congenital heart disease because of its autosomal dominant trait, and lot of patients, they are there and they are symptomatic, and treatment whichsoever is available is in the form of symptomatic relief by beta blockers or other antiarrhythmics and like that, but nothing is going to change the real face of the disease. Even surgical myomectomy or alcohol ablation, these are the procedures which are really very high tech, and this medicine has come recently, and we are going to go into the details of this, how a medicine can change the face of the disease. So we all know that it's hypertrophic cardiomyopathy is an abnormal muscles because of the genetic predisposition. And the guidelines of this, the patients with hypertrophic cardiomyopathy, either they are treated with, to relieve the symptoms, they are either treated with beta blockers or other antiarrhythmics. And the gradient, if it does not change otherwise, the beta blockers, they are going to slow down, and this is how they affect the gradient, but otherwise it's not changing the disease. And if the person, then septal ablation and all those, these are the techniques which are used to remove the gradient across the left ventricular outflow tract. And this medicine, which we are going to discuss in few slides, is a first-in-class selective-cardiac myosin inhibitor, and it has been approved in symptomatic obstructive hypertrophic cardiomyopathy. Is indicated for the treatment of adults with symptomatic NYHA class 2 and 3, and who have obstructive gradient as well. So for patients with obstructive hypertrophic cardiomyopathy who have persistent symptoms attributed to left ventricular outflow tract obstruction despite beta blockers or non-dihydropyridine calcium channel blockers, then this medicine is recommended so far, and it's class 1B indication, and it is in the European Society of Cardiology guidelines, and it is in American Heart Association guidelines as well. So mechanism, it reduces the number of myosin heads that can bind with actin, and thus normalizing the probability of force producing systolic and diastolic cross-bridge formation. So it reduces excessive contractility and dynamic left ventricular outflow tract obstruction, improves myocardial energetics and cardiac filling pressure in patients with hypertrophic cardiomyopathy. So this is, by doing this actually, it reduces the left ventricular outflow tract obstruction, normalizes diastolic function and quality of life and physical functioning. These are the trials which have been done from 2016 to 24, and most of them, they showed better results. We will be talking about one or two trials. The Explorer HCM trial, a phase 3 randomized double-blind placebo-controlled 30-week trial with more than 3,000 patients with hypertrophic cardiomyopathy and LVOT gradient of more than 50 millimeter and NYHA class 2 and 3. So these patients, they got benefit in terms of the gradient reduction as well as the oxygen consumption and NYHA class as well. You can see that 37% in the drug and the other placebo only 17%. So it's significantly reduced LVOT obstruction, means in change in post-exercise LVOT gradient, peak gradient, and you can see that this is on baseline at 30 weeks and how it is giving benefit. And this is a Valor HCM trial, long-term efficacy and safety of the drug, mavactum, which were treated with this in the previous trial, and then they were continued with the long-term use, and there was 82% benefit of this. And the patient, they needed less surgical intervention or non-surgical intervention. So with mavactum, significantly more patients improved by NYHA class, which was 63% of patients, they became NYHA class 1. And this is another study which also showed that this is a long-term study of more than 250 weeks and of treatment, and the benefit was there. So this is functional class improvement shown in this trial, long-term trial, and it is there in base 12 weeks, 48 weeks, and all those. And improved in class, some patients, they improved from class 3 to class 2, and some patients from class 2 to 1, and only few patients, they worsened, and why they worsened, we will be discussing it in little bit detail. So adverse effects are syncope and dizziness and heart failure. If this drug needs to be monitored by doing echocardiography, because it not only reduces the ventricular outflow tract obstruction, but may cause damage to the ventricle and reduce ejection fraction as well. And because its metabolism is through the cytochrome P450 system, and we know that the patients with different, they have different kind of cytochrome systems, so that some patients, they will need more drug, and some patients will need less drug, and some patients will be having more side effects and less side effects depending upon this. So it is rapidly absorbed by biphasic elimination profile, and in different cytochrome systems, actually it is, if they are normal metabolizer or poor metabolizer, so its half-life will change. And so this is how it has started, initially 5 milligram once daily, and then after 4 weeks, depending upon whether the gradient has reduced or not, and we can increase the medicine and can continue it. And if the ejection fraction drops less than 50%, then the drug is stopped, whether it is temporary stopping or it is a little longer time. So maintenance dose, it has been in different doses, even 2.5, 5, 10, 20 milligram, depending upon patients and their follow-up results on echo. So conclusion, it's a first novel therapy for HCM, effective and reversible myocardial relief, reduced need for surgery in high-risk HCM patients, improved NYHA class and exercise capacity, requires careful monitoring, integrated into updated guidelines. Thank you very much.
Thank you, Dr. Akhtar. Wonderful presentation, and we are really happy that we have this mavacamten over here. Just one question regarding the indication. In the last slide, there was some mention of Valsalva provocation, but would you start a patient who has a resting dynamic gradient of 30, and with provocation it goes beyond 50? So would you start on that as well, or a resting dynamic gradient of more than 50 and you start?
It is what